Ladies and gentlemen, it's a privilege for me to talk to you about pediatric hematopoietic stem cell transplantation. My background is about 33 years in this field, so it is a very important topic really to talk about, I believe. Pediatric diseases are treated by stem cell transplantation, both for acquired, like malignancies or some non-malignant diseases, or congenital immune deficiencies, hematologic defects, osteopetrosis, mucopolysaccharidosis, lysosomal diseases. How do we decide? This is an international grouping. It is from European Bone Marrow Transplantation Group. In every 3 years, they again write the indications for these diseases for stem cell transplantation, and we use these features for our applications. It's an evidence-based approach, and in these papers, we learn about every disease and whatever their disease status is like, and different donors. And accordingly, for example, AML, we chose CR, complete remission 1, high and very high risk. Okay, matched sibling, standard, matched unrelated donor, standard, but for haploidentical, clinical option, and autologous GNR, generally not recommended. This is repeated for every disease, so we know what we will do for these cases. This is, of course, not mandatory, but at least show us a way to approach. How do we find a donor for bone marrow transplantation? As you all know, we use HLA typing, but it is not that easy. We use serologic, cellular, molecular approaches. And as you know, it is on 6 chromosomes, and we are using 5 of them. These are A, B, C, and D, Q, DR. We are not using DP. And for each of them, we have 2 alleles. So it is a 10 allele system we are using. And we usually have a chance of 20 to 30% of finding a donor, except for consanguineous marriages. If you have such a big family, it is much more easier. And there is also a bank system in the world, matched unrelated donors. Now it is more than 30 million. They are voluntary. And 9 or 10 out of 10 loci, we usually accept changing from one disease to the other. How do we search for these donors? Okay, first we type the patient, parents, and siblings. If we have a HLA matching sibling, even 6 is enough, then we go on with transplant. If we don't, then we go on for the bank I had mentioned, and also some family search sometimes. And if we find a donor 10 out of 10 or 9 out of 10, then we go on with matched unrelated donor transplant. If we don't have, we either go on with chemotherapy, or we now, in these years, apply haploidentical transplant from mother, father, sometimes sibling. We have the other applications like pre-implantation. This is important because if there is a chronic disease and we want to save the child, plus we want the family to have a healthy child, then we use pre-implantation techniques. And this is the first one in 2000. It is for Fanconi aplastic anemia. It is IVF method, really. We choose the embryo without the disease and HLA matching and put into the mother. It is a well system. for some families, these are our own patients for different diseases. Mostly we are using it for beta thalassemia major or some congenital chronic diseases. What about ABO blood group? It is not important. It never affects the outcome, but during the application, according to the group of the donor and the recipient, we change red cells, plasma platelets to different groups accordingly, and at the end, it changes to donor group. What are our sources? We do allogeneic BMT with bone marrow or peripheral blood. It may be, as I mentioned, an HLA matched sibling or unrelated donor or mismatched family donor. Very rarely we have syngeneic BMT. This is aplastic anemia, one of them, and the other one was the donor, and it was very successful. We are using autologous bone marrow transplantation, mostly in solid tumors. This is for giving high dose chemotherapy. And we know that if we give this chemotherapy, the bone marrow of the recipient will be distracted. So we take the bone marrow first, freeze, and then go on with chemoradiotherapy and give back the bone marrow to save the patient. This is mostly used for solid tumors. Rarely we are using cord blood. So, now it is very popular to use gene transfer, but it is not in practical application still. How do we get it? For peripheral stem cells, we are using the apheresis equipment. For bone marrow, we are using the classical bone marrow taking from the iliac crest of the donor, then filter and give directly into the vein of this patient through the catheters. We also can collect cord blood stem cell, and they are all given to the patient. But before giving this stem cell, we have to prepare the patient. We usually use myeloablative applications so that we can destroy the bone marrow of the recipient and clean the disease as well, and also for immunologic reasons, because otherwise it will be rejected. So we prepare with different drugs and total body irradiation sometimes. But for older patients and non-malignant disease, you may use reduced intensity or sometimes non-myeloablative applications. What do we do? First, prepare the patient, then we find the stem cell source. As I mentioned, we do the conditioning 1 to 4 weeks, then we give the stem cells by central catheters. About in 1 month, the engraftment will occur. During this period, we keep the patient in a very special ward with filtered air, and everything is highly checked in these wards. And after engraftment, then we discharge the patient, but the story doesn't end, unfortunately. There are always early, late, acute problems, and late effects, maybe whole lifelong. You may imagine TBI, chemo, stem cell transplantation, and if you blow this, there will be, of course, early and urgent complications. And we have to be ready to face them. What are them? First, you must not forget one thing. We have to support the patient with blood products, infection prophylaxis, nutritional and GVHD prophylaxis, and psychosocial support. For example, after these chemotherapies and TBIs, the mucosa always get distracted, destroyed, and there comes this big problem, mostly in the mouth and skin. And at the end, if we don't clean it appropriately, the mouth might be like this. They can't eat. It is a very difficult situation. Mucositis. And infectious diseases, of course, before engraftment, during engraftment, post-engraftment, and late phase. Before engraftment, mostly bacterial infections are there and some fungal infections. But after engraftment, there comes the viral infections more. And if it is a late phase, mostly in chronic GVHDs, we again see encapsulated bacteria together with virus and fungal infections. This is our most difficult problem, acute graft versus host disease. The name is there, graft against the host. After we prepare the patient with radiotherapies, chemotherapies, there is always a tissue problem, and both by activation of antigen presenting cells and also donor T cells that differentiate and migrate, and recognizing class 1 and 2 cells, there comes immunoregulatory problem, and then target tissue destruction. This is very, very important. We've divided it into acute and chronic GVHDs. In the past, we used to say less than 100 days, it is acute, and after 100 days, it's chronic. But now this is not like that. It might be seen anytime. And skin is mostly affected, more than 80%. It starts with palmar and plantar areas first, then all the body, and it might be as severe as this. So it is a very, very difficult situation. Together with it, we had gastrointestinal tract problems about in 50%, and they have
Sema Hanım, sesinizi kapattınız. Sesiniz gelmiyor. Sesinizi bir açarsanız lütfen.
tekrar açtım.
Tamam, şu anda geldi. Devam edebilirsiniz lütfen. Ekranı full yapın lütfen tekrar.
Onu yapıyorum da şimdi olacak inşallah. Tamam.
Evet, tamam, devam edebilirsiniz lütfen.
When you look at the endoscopy, you may see such a bad situation, ulcerations, exudus, edema, and it is a very, very important problem. And the liver, we see in 50% cholestatic hyperbilirubinemia. And it is really sometimes a big, big, big problem. Then what do? We do the staging and then the grading. And you must not forget that for fourth grades, the chance of survival is only 5%. So we must either protect the patient from this complication, or we must treat it accordingly. What are the risk factors? Of course, HLA is the biggest problem, and the regimen, conditioning regimen we have used, stem cell source, and the infections. We treat them with different diseases. I don't go into detail, but just to see, we have to apply either immunosuppression, inhibition of cytoplasmic calcinuria, MMS, sirolimus, or immunologic methods like anti-thymocyte globulin, monoclonal antibodies, extracorporeal photopheresis, and cellular applications like mesenchymal stem cells. What about chronic? It is completely different. It is like mostly rheumatic diseases like scleroderma, and it is an autoimmunity and immunodeficiency picture. But it is also very important for mortality, so we must also be careful about it. What are the risk factors? Of course, if you start with acute, this goes to chronic, a older age, TBI, and etc. And as I mentioned, we have a patient different from the other one. It may be like this, and all these groups must work together for treating these patients. For treatment, if it is local, it is easy, but for disseminated diseases, you have to use different important immunosuppressive drugs. And also we have vascular endothelial syndromes. VOD is the most commonly seen of them. And it is a sinusoidal obstruction syndrome, SOS, from 5 to 70% in different reports. And in the hepatocytes, in these areas, there are bleedings. And after a time, there comes veno-occlusion. We see weight gain, tender hepatomegaly, and hyperbilirubinemia together with jaundice. These are for adult patients, but for pediatric patients, we are using these criteria now. And the most important of them is thrombocytopenia, and others are like the adult patients. What do we do for treatment? Maybe some of them might be familiar. Defibrotide is the only treatment for prophylaxis and also therapy. Late effects, a very long list because we are treating pediatric patients. They have a long life in front of them, and you may see every system getting some kind of late effect. Of course, secondary malignancies, going back to school, dental problems, these are very, very important for pediatric group. And for pediatric group, we have to plan vaccination, neurocognitive changes, quality of life, and also for these patients, it is very important to help to transition from pediatric to adult medicine. And it is like this, for BMT patient and BMT center are stuck to each other. First, I want to tell this is Galata Tower, and the Zeppelin at that time come to this tower for the people to get out. So it is like that. We are just like this. And we have to vaccinate these patients accordingly. It's a multidisciplinary approach, and we have to follow them for every system, and all these tables are used for this. What about our center? Now we are in MEDIPOL group, and it is a university, many different faculties together with medical faculties. This is the main hospital, but now we have a tower added to it just near this building. So we have better facilities now. This is our bone marrow transplantation group. I am the head of the pediatric hematology oncology and the principal investigator at the BMT unit, together with Yöntem Yaman, Muratelli, and Kürşat Özdilli. This is my boss who sent me to London for training in 1987. And from 1989 to 2011, I worked in Istanbul University, Istanbul School of Medicine, and I was the head of the pediatric BMT center there. And after that, I moved here for since 7 years. And I am also a JC inspector, going to other centers and check them. This is Yöntem Yaman. He is also trained in different important centers of Turkey, and he is with us since 6 years. And Professor Murat Elli is also from Istanbul University and specialized in different centers. And since 4 years, we are working together. And Kürşat is associate professor. She is head of the ward, the very important, and he's with us since 6 years now. And she is the head of all the laboratories and transfusion center, well-trained and helping us for every detail. We have every subspecialty covered in-house. And we have a pediatric ward with 16 beds, but now we'll have a separate ward for pediatric hematology oncology with 20 beds. And we have every outpatient facility and pediatric emergency. And all the laboratories are possible, and it is done in the center, pediatric surgery, TBIs, everything in the center. This is Turkey, going up with bone marrow transplantations, and 6,622 at 2018. Now it is almost near to 10,000. And in Europe, we caught up with the developed countries. Our numbers are getting higher. This is our number in this center, total 274, and we may do haplocord, MAD, matched sibling, and autologous transplantations. This is our group collecting bone marrow. And we are a member of EBMT, and pediatric BMT unit is completely separate from adult unit. We have now 11 beds, and we have the appropriate nursing, and we are doing, as I mentioned, every kind of bone marrow transplantation. And these are our patients. We are very happy. They are from different countries. For example, she's from Erbil, the Kurdish area in Iraq. We did the transplant for thalassemia. And all these, she is from, for leukemia, Kazakhstan. And this is the smiling face after a good, successful bone marrow transplantation. Thank you.